thank you. I think that's the last talk for the day. Not a topic that's that many people are fond of, but I just like to emphasize because this has a lot of implications on the outcome and management of the retinoblastoma. So it's very important that we include genetics, and it has been included as part of the staging as well at this point of time. So let's do a little basics. RB is retinoblastoma is caused by the neural retina specific alteration of the RB1 gene, and inactivation of both the alleles are necessary for the retinoblastoma formation. Now, tumors are caused by genetic aberrations. That is, the retinoblastoma tumors are caused by genetic aberrations, but that does not mean that all patients inherit the disease, and does not mean that tumor in all cases are heritable by the next generation. Some tumors are caused by RB1 mutation, others by amplification of the MECN gene. This is introducing you to all the terminologies in the genetics. Now, looking at, I think we'll have to shift our focus to the heritable and the unilateral and bilaterality. So, heritable retinoblastoma has a high risk of other cancers, increased risk of RB in siblings and offsprings. Usually, alterations are identified in blood. And the non-heritable entity has no risk of other cancers, reduced risk of RB in siblings and offsprings, and usually alterations are identified only in the tumor. Now, with our 1,500 cases over the past 20 years, we took up 450 probands for genetic analysis along with their parents and siblings. So we established the stepwise method for the RB1 analysis. One, we did the Sanger sequencing for the known point mutations, which is already existing in literature, 90% somatic and germline. Then we went ahead and did the MLPA for the deletions and duplications. Then we did the MS-MLPA for the somatic changes. And this has been published also. The next thing we went about doing was the next generation sequencing facility, which helped us identify the new pathogenic variants, which could not be identified with the conventional methods. So overall, we saw about 20 new mutations, which was novel to our population. And of the lot, we saw about 38% showing a nonsense mutation, 20% deletions. And then we did have some missense, and we also had other indels and splice mutations, which were also a significant number. And the timeline we took for doing this analysis was, we started off with the first week. And when the patient comes up for follow-up in the fourth week, that is the start of the fourth week, we would be able to generate the results, and the counseling would be done in the first follow-up visit. So the next important thing, especially in our parts of the country, especially in the developing world, is the cost of genetic analysis. We brought down the cost of genetic analysis to an equivalent of $250. And we had about a sensitivity of 95% for somatic mutations and 90% for germline mutations in the bilateral RB patient's blood. So the major outcomes were we could identify the familial RB, could make out the twin discordance. We did an analysis of de novo germline mutations as somatic mutations. Could also do a prenatal identification. So I'll go through some of the case scenarios. Here it was a proband who presented to us at 4 months, and he had a bilateral RB, and we realized that the mother had enucleated earlier on in her life. And we did not know the reason, but we assumed it would be a retinoblastoma. So in the subsequent follow-up, when the mother turned out to be pregnant, we decided to go ahead and do a genetic analysis and found out that the mother and the first child had a similar mutation. And then we asked the mother to bring the child as soon as the child was born. So the younger sibling was brought to us when she was 12 days old, and she was found to have group B retinoblastoma in both eyes, which was easy for us to treat. Of course, as Santosh was mentioning earlier, in our part, it's very difficult to do an intra-arterial chemotherapy. So we went ahead and did an intravenous chemotherapy and salvaged not only the eyes, but also the vision of the younger sibling. The second scenario was the proband presented to us at 36 months of age. There was no family history of retinoblastoma. It was a unilateral group E retinoblastoma, but then we found a germline mutation in the blood of the patient, which means it is a heritable entity. So the next one was a proband was 26 months old with a group E retinoblastoma. Germline mutation was identified and the child was closely monitored and the patient turned bilateral during the treatment period. And analysis of parents showed the father as an unaffected carrier. So there was a prediction of a higher risk for the next sibling. Now, this was a 3-year-old male with a group E retinoblastoma with a retinal detachment with no family history of retinoblastoma. A primary enucleation was done and a homozygous methylation only in the proband's tumor was identified. Now, in the older patients, now after having listened to all these patients, the younger ones who had been enucleated about 20 years ago started reporting to us, asking us for knowing whether there is a risk of retinoblastoma in the offspring. So this was a unilateral patient whose eye was enucleated for retinoblastoma. There's no family history of retinoblastoma and no mutation was found in the patient's blood. And so therefore we predicted a less than 1% chance of getting RB in her offspring. She got married and she also delivered a child who was brought to us and did not have any retinoblastoma. Risk of secondary tumors. There are children who come to us after 20 years wanting to know whether there is any other chance of having a secondary tumor. Again, this child was enucleated at the age of 2 and she wanted to know whether there was a chance of secondary tumor. But since the blood did not show any mutation, we said that there was not going to be a risk of secondary tumor. So this is a 20-year-old female unilateral retinoblastoma enucleated at 1 year of age, and genetic testing unfortunately showed a germline mutation which is heritable. So this was a 24-year-old female with a unilateral retinoblastoma enucleated at 2 years of age. No family history, heritable nonsense mutation was identified, and this was counseled to the patient. In another scenario, there was a familial RB. This was a very interesting family with 4 affected members. The proband's wife was 2 months pregnant. So the proband and the mother had heterozygous deletion of exons 3 to 13. And then the prenatal testing was done for the proband's baby, and the same deletion was found in the fetal DNA, unfortunately. So then after having done all this, we started to go ahead and do the identifying the copy number gain and loss, which was discussed by Dr. Chantada. And we are now looking for copy number gain and loss in cancer genes through the targeted NGS. Epigenetic alterations, apart from the genetic changes, also plays a major role in progression. So whole genome level epigenetic changes are being studied by the methyl arrays and the microRNA profiling. Now, we also did a little bit on understanding the mechanism of chemoresistance. In spite of various treatment modalities, still about 30% of the patients do not respond to the current therapy, and we are now in the process of elucidating the possible mechanism of therapeutic resistance using various cellular assays. And what we found out was there was an increased expression of stem cell markers in non-responsive eyes, which provides an evidence of cancer stem cells and therapeutic resistance. And there is another interesting finding that we found out was there were somatic mutations were found in patients whose parents had an age difference of less than 10 years. And there was de novo germline mutations in RB patients whose parents had more than 10 years of difference. Here, the social setup is such that the age difference is usually 10 years or more until about 10, 15 years ago. But now people have started realizing and the age difference has significantly come down. But this was a finding that we found out, which was quite significant. So to summarize, identification of the RB1 germline status of a patient allows differentiation between sporadic and heritable retinoblastoma. Genetic testing and genetic counseling is crucial for assessing short-term risk of additional tumors in the same eye, other eye, and the prognosis, and long-term risk of non-ocular malignant tumors as well. So it is important that every patient with retinoblastoma requires to go through a genetic analysis. Thank you very much for the opportunity.